Hello, everyone, and welcome to OHI University. In today's webinar, Clinical Benefits of GaitScan as an Aid to Diagnosis and a Guide to Treatment. My name is Mike Miller. I'm the Director of Marketing here at OHI. Thank you very much for taking the time to join us today. To start off, I would like to make sure that the audio is working and you can hear me clearly. You can activate the audio using a computer or your phone. If your computer audio is not working, you can call in using the phone number and access code shown on the dashboard. Before we start, I'd like to explain a few functions on the GoToWebinar control panel, which is on the right side of your screen. There are a number of icons, a microphone with the red slash through it, and a square with the question mark. The red slash through the microphone means that you are on mute. The reason we do this is to manage all of the background noise. We do encourage you to ask questions. Simply click on the icon that is a square with a question mark in it, and you will see a chat box appear, and you can enter your questions there. We will wait till the end to answer all questions, and if we do not get to your question today, we will email you with a response. Today's webinar is being recorded and will be available by Monday. Today's webinar is being presented by Dr. Paul Barrett. Dr. Barrett qualified from Queen's University Belfast in 1995 before moving to the University of Ulster to undertake research on the effect of orthotics on the lower limb kinetics and kinematics, with specific interest in patellofemoral knee pain. He is currently the Chief Clinical Officer for OHI. Dr. Barrett has lectured throughout Europe on lower limb biomechanics and treatment using orthotic therapy and consulted with professional athletes and international teams with a keen interest in sports injury, pre- and post-operative care, and management of the chronic inflammatory conditions. Please welcome Dr. Paul Barrett.
Thanks, Mike. Hi, everybody, and welcome this morning or this afternoon or wherever you may be. I want to talk today a little bit about the clinical benefits of GaitScan as an aid to diagnosis and a guide to treatment. So today we're not going to be doing a classical seminar on lower limb mechanics. I want to teach you maybe today, or I want you to go home today and ask yourself the question, are you using GaitScan enough, or could you be using it a little bit more or in a different way? I think if you do that, if it generates a little bit of thought in that direction, I think it will be a success. First question is, how many people use their GaitScan every day? I would suspect that if I could see a show of hands, it wouldn't be everybody. Most people get a GaitScan and it goes into a cupboard and it's brought out maybe every other Thursday or once a month, or it's brought out whenever somebody needs to have a GaitScan done for a pair of orthotics. The second question is, how many people use the GaitScan as a tool to guide rehabilitation within the clinic, or as a tool to assess for rehabilitation within the clinic? And again, it's probably not as high a number as it could be. These are things that I feel the GaitScan is very useful for and it's very underutilized for. So what I want to do is I want to show how we can use GaitScan a little bit more. GaitScan isn't only an orthotic prescriptive device. I know it's very often looked at it, but it looked like that because it's attached to an orthotics lab. It's a very powerful aid to diagnosis. But what I want everybody to remember is it's not a diagnostic tool. We are the diagnostic tools. The GaitScan is an aid to diagnosis. We can use it to guide us into which direction we want to move to our assessment or with our treatment. So I'm going to talk today about things called flags. And flags are the way I've been describing. I've been using GaitScan, by the way, for 21 years. And I've been talking in terms of flags for probably 15 of those years. I talk about this a lot over in Europe. So if there's anybody on the call from Europe, you'll probably be asleep in 15 minutes because you'll have heard me talk about this. Flags are anomalies in GaitScan that are created by aberrant mechanics. So they're things you're going to see in the GaitScan that are not normal. And really what we need to use GaitScan for, we should use GaitScan for, is to be able to identify where we see the flag and then be able to direct assessment and treatment to determine why that flag's there. And hopefully I'll describe that a little bit better as we move on. So I'm going to talk about a 5-point plan for assessment GaitScan. 5-point plan was developed over here in Europe. We've been using it for the last probably 18 years, and it was developed really because of the way initially when I started with the company, the way I worked myself. It's a simplistic way of looking at it, which allows our patients to really become invested in the treatment because they also understand. And when they understand, they're more likely to become invested in what we're trying to achieve. It also has 2 parts. Static, which is all about rehabilitation and is underutilized. So we're going to talk in depth about that now. And dynamic, which is all about functional control. So let's look at the static. Static's all about weight distribution and how many toes. So when we look at a static assessment, no toes means tight calves. That sounds like a very simplistic term, but it's a flag. When we look at a GaitScan that has no toes on it during the static scan, that we should look at that as a flag. Now again, we're talking about flags. So when we see a flag, it means we need to have a more detailed examination. Having no toes on a scan could be for a lot of different reasons. It could be that we have retracted digits. It could be a patient with rheumatoid arthritis. It could be a patient who has just run over their foot with a lawnmower. It could be someone who has a very tight calf muscle and they've got extensor substitution. So their toes are retracted slightly as a compensation for tightness of the gastric. It could be a whole lot of different reasons. It could be tibialis anterior hypertonicity. So our job is to look at it, identify that there's a flag, and when we identify the flag, then we investigate. And that investigation is something that you can build into what you do in your daily practice. The second one is weight distribution. So when you see a significant difference in weight distribution, this is a flag. Now again, it doesn't mean that we have a leg length difference, an anatomical leg length difference that needs a heel raise. It's just a flag to indicate that something is not right. Now, this could be a whole lot of different things. It could be a functional leg length problem, it could be anatomical, it could be a pain avoidance, weak hip stabilizers, we could have a problem with the sacroiliac joint. The flag highlights the need for a more full investigation as to why the anomaly is present. What I'm going to do now is switch to a, okay, so now you should be able to see the GaitScan. So this is a typical static scan. So what we're looking at here is something that is very underutilized within GaitScan. We use GaitScan a lot. We use the dynamic scan. We move straight to orthotics. When we have a GaitScan system, if we scan every single patient that walks in our door, not with regards to an orthotic, but just to do the static scan, what we will find is that we will gather a lot of information and we will generate treatments, we will generate appointments, further appointments that will benefit the patient. So when we look at this patient has no toes. This is a friend of mine, so I know that he's not rheumatoid. I know that he doesn't have retracted digits. He hasn't lost all his toes in a horrible accident. He has a very tight calf muscle and he's got extensor substitution. So if patients all came into your clinic and they were all scanned, they all had a static scan done, then this points straight away towards an assessment to decide whether or not this is tightness in the calf muscle, tightness in the soleus muscle. Is it a bony block equinus? Is the tibialis anterior hypertonic? If it is a hypertonic, then the peroneus longus is going to be hypotonic. So straight away, you're able, just by looking at a static scan which is showing no toes, to identify 4, 5, 6 different pathologies that require treatment. or different areas that could benefit from treatment. This patient would or could be booked in for an appointment to assess, to find out which one of the aforementioned needs treatment. Then you would look at it and decide whether or not you're going to work on strengthening for the peroneus longus, you're going to do a program of stretching for tibialis anterior. Do you want to do deep tissue massage on the calf muscle? Do we want to do dry needling in the calf muscling or myofascial release? So it becomes more than just stand on the plate for 5 seconds, step off, and let's get you into an orthotic. It generates an appointment for rehabilitation, and it's not needless rehabilitation. The reason it's not needless rehabilitation is because when you see no toes on a scan, it will generally be due to a tight posterior compartment. And when the posterior compartment is tight and it limits ankle dorsiflexion, it moves to the next joint, which is your subtalar joint, and the body then will pronate through subtalar joint to gain the dorsiflexion that it's trying to achieve. So you will get that extra amount of pronation happening, which then can cause the internal rotation, can cause other problems further up the kinetic chain. It's very important that if you are going to put this patient into an orthotic down the line, that you do address that. Because if you put a patient into an orthotic but don't address the fact that their posterior compartment's tight, their foot will try to pronate heavily against the insole. And the insole will feel either too high, too hard, it will blister the arch, and it will feel uncomfortable. So bringing a patient, if you see 100 patients in a week and you bring them in and you just scan them all and show them the static scan, not discussing orthotics, straight away, this patient is booked in or should be booked in for an appointment for an investigation to see why they've no toes hitting the mat. When you see their static scan, you can see also that their weight distribution is off 56 to 43. And again, when we see this, I generally round this, so it'll be 15%. If I was talking to this patient, I would say you're off by about 15%, which is significant. I would classify anything over 5% difference as something that would become significant. So again, this is a flag, as we discussed, but it doesn't mean that we're short on one side or long on the other side. It means that there's a possibility there's a leg length. If there's a possibility there's pain avoidance. This could be that the left hip's very painful, or there's a corn on the big toe on the left side, so the patient's trying to offload it. So the flag is telling you to investigate. And then when you investigate, you will be able to find what needs treatment. Whether it's weakness through the glutes, whether it's like a Trendelenburg drop on one side and non-neurological, whether it's a sacroiliac joint rotation, whether it's pain avoidance pattern, whether it's an anatomical leg length. But again, this indicates that there's a need for a more in-depth assessment to identify why the anomaly is there and it needs to be treated. And it's one of the things that we have seen over the last few years. We have some customers who do a lot of volume of orthotics, but they use the GaitScan every single day. They use the GaitScan on all of their patients, but they use the GaitScan not only for orthotics, but also to drive rehabilitation within their practice. And this may be something that you're doing anyway, but when you show a patient this, it's the same as before, as we've discussed before. A picture paints 1,000 words, and patients, when they see this, they know straight away, they get it. They understand that, okay, that I should have more toes than this hitting the ground. And they understand that weight distribution of 15% overloaded onto the right side is not going to be good long-term for their right hip or for their right knee, especially if they're into sport or they want to get into sport. So what we get then is, as a result of the static scan alone, you're going to book the patient in probably for an assessment of the calf muscles or posterior compartment. You're going to treat to release posterior compartment, treat to stretch tibialis anterior, probably then strengthen peroneus longus. We're going to do a full pelvis assessment, sacroiliac assessment, and rehab for hip stabilizers. This is all just from looking at a static scan. And everything that is done, everything that you do will help down the line, especially if you're going to go down the route of treating this patient long term, or if they do move into a pair of orthotics. Everything that's done here will help the orthotic to be effective. When we look at dynamic, when we move from there to the dynamic, and the beauty of doing a static scan is that when you do a static scan, you have to do the dynamic first to get to it. So when we do the dynamic scan, we can mark our flags or markers on it, and then we can have a chat to the patient. And very often the patient will ask, you just show it to them very quickly, and they'll ask what's happening with my feet. Do I need a pair of orthotics? This can be done after 2 or 3 appointments, but it's certainly something you would then introduce into the treatment plan. I use the pain. There's a little pain button which allows you to rate pain on 1 to 10 on the visual analog scale. So I tend to use it just to identify flags, so that if I'm sending a scan off to a patient, what I do is I put it in, I say, like, anywhere where there's a problem, I'll just mark it with an X. So I put in problem. So sometimes I'll put in problem 1, problem 2, problem 3, problem 4. But these are essentially flags that we're going to use to identify areas that can cause pathology. So very simple. When we're looking at the GaitScan, we're thinking of 3 things for dynamic GaitScan. We're thinking of speed, we're thinking of symmetry, and we're thinking of stability. So it keeps it really, really simple, and it allows you to very clearly explain to a patient what's happening with their feet, why that's creating a problem for them, tie it into the pathology that they're having, and then show them how you can control that with an orthotic and with the rehab program that you're also working on. So let's start with speed. Speed is obviously the bubble moving at increased speed is a flag indicating poor eccentric control. When the line turns black and the bubble slows down, this is a flag which indicates rotation rather than forward movement. So I'm going to be jumping backwards and forwards a little bit here, but I think it's probably easier. So we're going to go with speed. So we've indicated 2 flags when we discuss speed. If I hit the play button, we're going to look at this bubble. Now, when the bubble's moving fast, then it's moving eccentrically. It's not controlled. It's moving at a very erratic pace. If you move into, can you imagine moving into end range at a very quick rate? Eccentrically, you're not controlling the range of movement of the joint, and it puts stress on the tissue. So we can see this bubble on the left foot. If we watch it, it hits the ground at the rear foot and it squirts through quickly. Then it stops nearly, goes through quickly, and now it slows way down again, and then it goes through again very quickly. Okay? What we're getting here is poor eccentric control through the parts of the scan where you can see the dots further apart, and where you see all the dots are on top of each other and the line has turned black. What you get then is the actual bubble has stopped moving forward and is now rotating. So it's stopped moving through sagittal plane and it's now moving through transverse or frontal plane. So we're now getting rotation built into the loading phase, which is not something we really want to have. What we want is for this to go through at a nice, smooth, controlled rate, Not too fast, not too slow. We don't want it to speed up. We don't want it to slow down. We want it to be at a nice, smooth, controlled rate. Remember, each one of these dots is like shutter speed in the camera, and there's 300 images taken every second. So the further apart they are, the faster the foot's loading. So you can see from a glance that this is loading through the rear foot quite quickly. And you can see from a glance that it's moving quite quickly through toe off. And you can see on the right foot that it's moving through midfoot as the foot's loading quite quickly. You can also see that where the knee loads here, there's a little rotation happening. So you can see the line has a little blip in it, but you can also see that we've got a nice black area here. And again, these are flags. This is a flag to say the foot is not loading in a controlled way. And we'll get into that in a little while about the pathology that that causes. This is a flag to say that there's rotation happening at the knee. What does rotation do at the knee? It can cause internal issues, can cause meniscal problems, it can cause patellofemoral issues with malalignment. And again, once we move to the top here, we can see that again, we have rotation happening at the forefoot. So this is all hip, this is all pelvis, because when the foot gets to here, it's trying to twist, to rotate, to move into propulsion. And that's normally an indicator that first MTP joint's not functioning properly. So if it can't bend, we can't pivot within the normal sagittal plane. So we twist and we rotate through transverse plane. You will see this all the time. You will see this in patients when they're walking because they'll have a little bit of an abductory twist in their foot, or you'll see their pelvis, they've got a little bit more of a transverse rotation or a wiggle, so to speak, as they walk. You can see their pelvis rotates a little bit more. Stability is the next S that we talk about. So stability is the next S. The gait line should be a gentle curve. If the line is completely straight, that's a flag because it's not showing a nice gentle curve round up the outside of the foot onto the first and back off. A straight gait line is a very unstable gait line. If there's a twist in the line anywhere, but like we were talking about with the areas of black, where if there's a zigzag or a twist, then that's a flag because of rotation, okay? If the gait line starts halfway up the foot, I'm sure everybody here that has done a scan and they'll have seen the gait line start halfway up the foot, that's a flag. But it could be foot drop. It could be someone who's had Achilles surgery. It could be someone who's a toe walker. Flags are just telling us what is wrong on the scan, and then we go to that area and we decide, we do our diagnostic with the patient, we get our hands on, we take a good history, and we find out why that is happening. We'll go back to stability, we'll talk through symmetry, and symmetry is very, very simple. Symmetry is when you see asymmetrical gait pattern. This is normally a flag for me. I'll look at that and it'll be a flag for some sort of a leg length problem, normally a functional leg length difference. And it ties in very nicely in this case with the static scan, which is overloaded onto the right side. So again, the static scan is telling you that the patient's overloading 15%, but it's not saying whether it's sacroiliac joint, it's not saying whether it's a hip stabilizers or the glutes or whatever. Now what we're seeing is we've got, you know, an internal rotation on the right side, or ASIS is going to be pushed anterior on the right side and posterior on the left side. So we are going to get a rotation happening through SIJ. So that's sort of fine tuning the need to really go and have a look at this patient's sacroiliac joint and to determine whether or not this person has a leg length difference, and if so, is it functional, is it reducible? So when we look at that, again, we look at the stability. So we're looking at anything with a kink. There's a kink in the line here. There's a kink in the line here. There's a big twist in the line here. It's not a nice natural curve. The line should come up the outside of the foot, should roll over onto the first and then bend back out as the foot supinates. Anything where there's a kink or a twist, it indicates there's rotation happening, and rotation has been entered into this system. And remember, the lower limbs and a very efficient pulley system. There are certain areas where you can get away with a little bit of rotation, like the knee can give you 10 to 15 degrees of rotation, but it's a very efficient pulley system. And pulley systems do not like rotation. They like linear movement. And if you can move through sagittal plane, through the foot, then everything above it will function in as close to a linear fashion as possible, which means that mechanically everything will function very well. Your calf, your hamstrings, your quads, all the way up through hip flexors. As soon as you put rotation into a linear system, you're going to have problems. So we try to avoid a lot of that rotation where possible. We talked about a gait line as well that is straight. So let's ping over this one. So now we've got a gait line on the left side. I hope everybody can see. This one's fairly straight. And a straight gait line is a very unstable gait line. The best way to think about it is when you take a line, a gait line, it should come up the outside of the foot, roll over, and come back out. When we used to make orthotics by hammering nails into bits of plaster, we would have put a nail in here and a nail here, and you would have had it from here to here, here down, and that's your sort of golden triangle where you're getting a lot of stability if you've got a good sized triangle here, because the area under that triangle is the sort of area that gives you a lot of your stability. And if you imagine the line comes up and across from here to here, you're getting a good triangle, okay? You're getting a good amount of stability. Now, we had a lecturer who used to say if you had a three-legged stool and all your legs were quite far apart, so you had one here, and one here, you'd be okay. You could sit in that stool and not topple. Whereas if you have a stool like this where you've got one leg here, and one leg here, you have to balance on it rather than it allowing you to sit on it. So there's no stability. So the flatter and straighter the gait line, the less stability. And again, what we had with this patient was the asymmetrical. We have the right foot which wants to roll in, we have the left foot which wants to roll out. So in this occasion, we're going to have ASIS pushed forward on the right side and ASIS pushed posterior on the left side. And again, that's a flag that I would say, with myself being a podiatrist, I work very closely with a number of different physicians, a chiropractor and a physiotherapist, and I would send them the scan and say, would you investigate, have a look at SIJ, have a look at pelvic stability and whatnot, and they will investigate that. But I always refer this to whichever one has sent the patient to me. So just to recap on that, we have flags. We've got a patient here, and we've got flags. We've got a flag here which is very quick, poor eccentric loading through the rear foot. Another flag because we've got a rotation happening at the knee, which isn't ideal. We have a flag at the forefoot because we've got a lot of rotation happening through the second, third metatarsal head. And we have a flag out here because our first MTP joint doesn't want to play. So he is lifted up off the ground and there's very minimal amount of pressure through there. So again, we want to test to see, is this a first metatarsal limited, anatomical limited position? Or is it a rigid first MTP joint? Or is it just a painful first MTP joint? Or most commonly, it's a hypermobile first ray, which hits the ground, elevates, and then doesn't want to work anymore. So it has to offload. We've got a flag over here, which is this part here between here and here of the scan is tibialis anterior. So it's your forefoot loading. So as your forefoot loads, your tibialis anterior works eccentrically to control the pronation of the forefoot onto the ground. So when it's not doing that properly, if you've got a hypertonic tibialis anterior, the foot tends to slap down very quickly. So it functions a bit, it looks a bit like a forefoot varus, but it's more like it's a mobile inverted forefoot. So it's a supinatus, it's reducible. So it's very important then to work on stretching tibialis anterior, trying to get function back into it. So as a result of your dynamic gait scan, you can look at controlling the aberrant mechanics, but you also then would look at the assessment and treatment for tibialis posterior because of the eccentric loading through the rear foot, proprioception exercises, because on the left side the patient's so lateral, they're rolling laterally so much that they're going to put a lot of stress through their ATFL ligament. You look at the knee, examine the knee. It's unlikely that a patient will come to you with no pain with internal derangement of the knee, with either cruciate problem or a meniscal problem. But it's very common. Something that I see is patients come into me and they have maltracking patella. They already have chondromalacia patella. They have a nice crunchy kneecap when you do the test, and they don't have a lot of pain with it. But again, they've got the rotation happening when they're walking. They've got the softening of the cartilage. So at that point, we treat, or we wait until the pain actually arrives. And at that point, then it becomes very difficult to treat. And re-emphasis on hip stabilizer exercises. So straight away, I think when we turn GaitScan around and turn the focus of GaitScan around, what we're looking at is this is a device which is really, really useful in your practice, because if everybody gets walked across the GaitScan, you will be able to identify a lot of potential problems that need treated, that potential appointments that will drive revenue in your practice, but will benefit the patient. Because too often a patient who gets an orthotic but doesn't do the work to stretch tibialis anterior, or doesn't do the work to stretch the calf muscle to give a little bit more movement through the ankle joint and prevent that movement through subtalar joint, or they don't do the work on their glutes to try to control their hip so that as their foot hits the ground, their hip drops and they get that pronation through femoral pronation or femoral internal rotation. So all of those things are very useful. I think an orthotic on its own will give you a certain amount of benefit. And I think rehab on its own will give you a certain amount of benefit. But when you add stress when you have stress on tissue because of either rotation or because of poor eccentric loading, the first thing we have to do is we have to remove the tissue stress. If we don't remove the tissue stress, then we can rehab that all we like. But it's a bit like somebody banging their head on their wall all day and then at nighttime taking 2 paracetamol or 2 Tylenol. You got to stop banging your head in the wall. So that's really what the orthotic does, is it tries to control the aberrant mechanics to allow the rehabilitation to have a much better effect long term. We're going to distill that down just a little bit more. So we're going to look at contact phase and propulsion phase pathology. Contact phase. So when our foot hits the ground, nearly everybody hits the ground in an inverted to an everted position. Some people will in a very, very everted, flat-footed position, but we're talking about the majority of people. So we will hit the ground inverted to eversion. With poor eccentric control, we get the uncontrolled end range loading. So it's like we've spoken about. If anybody moved into end range really, really quick over and over and over and over and over again, the tissue, the ligaments, the muscles that are trying to control that motion will become stressed and they will break down. So when we take 10,000 steps a day, every time we take a step and our foot hits the ground inverted and collapses in really quickly into an everted position, it puts a lot of stress on tissue. It also means that the sustentaculum tali rolls, and in turn then allows the talus to slide off the top of the sustentaculum tali, which is at the side of the calcaneum. So it slides anterior, inferior, and medially. It's a bit like a man sitting on a saddle on a horse's back. If the saddle slides medially, the man on top slides medially as well. And that causes the first MTP joint to load early. When the first MTP joint loads early, it elevates and it doesn't bend anymore. Because the key to the first MTP joint working is for it to be plantar flexed and for the base to be elevated. It has to be plantar flexed to allow the hallux to climb up on top of the joint. Contact phase tissue stress. Okay, so we've just discussed eccentric loading, inverted to everted. Tib post's primary function is as an inverter and plantar flexor, but it also works in an eccentric capacity. When the foot hits the ground very quickly and moves into eversion very quickly, the foot abducts and it pulls the tendon around underneath the sustentaculum tali, and it puts a lot of stress on the tendon. Over years, it can just wear away at the tendon starts to fray. Contact phase, when it happens very quickly into eversion, you get tension in the plantar fascia, which loses its functional capacity as a resupinator as an effect. You get increased heel contact phase. So heel contact time, when that increases, it stresses the tibia, the Achilles tendon. And it stresses the Achilles tendon because the Achilles tendon needs to get off the ground. The heel needs to lift off the ground at about 45% of the gait cycle. By lifting the heel off the ground, the knee bends. When the knee bends, the gastroc decompresses, so to speak. It offloads, and that can take a lot of stress off the Achilles. An internal knee rotation. If we move inverted to everted, as I've said, if the sustentaculum tali drops, if the talus slides medially, the talus is going to internally rotate as well. What are the pathologies associated with contact phase? So when we see, we've looked at the heel. When we look at the heel and we see the flag for really fast loading or for the knee loading very quickly, what we're going to see all the time are the same injuries over and over. There are some weird and wonderful ones, but as a podiatrist treating patients for 20 plus years, you see a lot of calcaneal enthesitis. You get a lot of referrals for plantar fasciitis, but it's actually the insertion of the plantar fascia into the calcaneum that causes all the problems. You can have Achilles tendon pathology at contact phase. You can have plantar fasciitis. At times it can become inflamed. You have posterior tibial dysfunction. Again, tib post dysfunction is a really underdiagnosed problem because most people go to the GP or go to the doctor and the doctor will say, you've got plantar fasciitis, we'll inject them. But a lot of patients, it's actually posterior tibial dysfunction they have. Whenever you see the heel loading really quickly, it's the tib post that's under a lot of stress. And the tib post inserts into everywhere. The easiest way to remember tib post insertion in the foot is that it inserts pretty much into everywhere in the mid-tarsal joint except the base of the first. So that gives you a fairly easy way to remember that. So you can have generalized arch pain, and you can, in the navicular and the cuboid or the first cuneiform, or there's lots of areas where it's painful, and very often it's actually tibialis posterior insertional pain. And if you move your thumb up the inside of the shin, it'll be very painful too. Again, medial knee pain and patellofemoral pain. These are all the ones that you look at contact phase pathology. And when you see certain things on a scan, immediately those are flags, and those flags direct you towards these pathologies. And where you see one, you will see others. Very often I will see patients who have post-tib dysfunction, and straight away I will go down and test calcaneal enthesitis, and I'll get pain through there. And when you look at the patellofemoral joint, they've got a lot of maltracking. They've got real weakness through their VMO, and they've got a history of knee pain. But they attribute the knee pain because their grandfather had knee pain and their mother has knee pain, so they put it down to something completely different. So when you look at contact phase, it's the same mechanism that causes all of these things. So it's not uncommon to have them stacked on top of each other. So always look for a couple. How are they represented? Again, very simple. Here's a flag, very quick through the rear foot. Here's another flag, lovely little area of dark on the gait line. That dark is rotation. That means this foot's no longer moving forward, it's now rotating. And it'll either rotate in the transverse or frontal planes. Can't do anything else. Here's another one. Here's a flag, real squirt through the rear foot, really quick. Look at this big hook. So it goes forward and then there's a real rotation, a real twist happening at the knee. So again, it's not telling us that this person's got damaged knee. It's telling us that we need to look a little bit more and examine the knee to see is there anything that we need to look at now. Again, same again, really, really, really quick through the rear foot. I mean, this is super quick, very, very poor eccentric loading through the rear foot. And there could be lots of reasons for this. Could be very, very tight calf muscle on equinus foot. Could be lots of reasons. But when you go through rear foot to forefoot really quickly and you build into that inversion to eversion, you will have stress through tib post. Okay. This is a graph that we would use, that I would use quite a lot when I'm looking if I have a patient with Achilles tendinopathy. And this is useful because I don't use the report very often, if I'm being brutally honest. But where I do use it is in this occasion. So what we can see here is we can see that medial and lateral heel hit the ground at 0, which is good, and it moves all the way through. Now the forefoot are all loading in around 10% of the gait cycle, so they're loading really early. The heel is still stuck on the ground at just after 70% of the gait cycle. So what we have got is a case where the forefoot's got down really quick, the heel's stuck, probably because the foot has collapsed internally, and it then has to externally rotate, and as it externally rotates to move off, the heel is still stuck to the ground. But this is going to increase the stress through the Achilles. So again, you see that in a patient who's coming into you, either if they're having a pre-medical and they're wanting advice on what running shoes to wear, straight away you would be looking at that and saying, you know what, your Achilles is under a lot of stress. I would advise you to go towards a Brooks Ghost because it's got a higher rise, and a rise is just the height at the heel when you take away the forefoot. So a rise of in and around 11 is a very good rise. It's quite a high rise, which will offload the Achilles a little bit. So I think the new Brooks Ghost 14 has a rise of about 11 or 12 millimeters. Hoka give a lot of cushioning, and they have a rise of about 8, maybe 9 at times. So you would look at a footwear and you would say, okay, a footwear with a good rise, good stretching and control, get the forefoot to come down onto the ground much later, okay, would offload the stress on the Achilles. Same thing if it's injured, you do exactly the same thing. You're just going to have to treat it as well at the same time. So contact phase leads, or phase pronation or inversion to eversion leads to propulsive phase supination. So this is where we get our flags at the rear foot that are going to cause this contact phase damage will then cause further problems later on. When we load the forefoot early, we load the first MTP joint early, we take away the ability of it to bend. Now, sometimes it's anatomical and it can't bend physically, and I'm going to show you 2 scans which indicate that. But we don't know that. We don't know that from a scan. That's where we have to find out, and that's why we have to put that into the examination findings or into the notes. What we want to do, the most common foot type is a functional hallux limitus, which is a hypermobile first ray. The first ray hits the ground, it elevates. As it elevates, it stops the big toe bending, and then we have to generate forward propulsion by externally rotating rather than by rolling through first MTP joint. That's a problem, okay? So propulsive phase, resultant compensation. Foot supinates early to facilitate forward momentum or forward movement. So lots of pathology caused by resultant compensation. So this is where we look at the foot and we go, contact phase is generally always inside. It's always medial. You've got medial shin, you've got, medial heel, you've got the plantar fascia, medial part of the foot, you've got, hallux abductovalgus, you've got all sorts of things, and medial knee. You've got all sorts of medial problems. Now we're going to move lateral, because when we have to externally rotate, we get all these laterally dominated problems. And I'm going to bring you back to the scan to show you after this. So some of the things we would look for would be Morton's neuroma, ATFL ligament, lateral ligament problems, ITB, runner's knee. So you're looking at very tight iliotibial band. So runner's knee where it flicks over Gerdy's tubercle, or inflammation at the greater trochanter where you've got maybe a trochanteric bursitis from your hip flexors, or whether you've just got inflammation of the ITB. You've got external rotators of the hip becoming really overworked, so you can get piriformis syndrome. You've got weakness of the glute med and min. You've got overworking of the iliacus and psoas major. So those are the real things. Those are the things that you will see all the time. I see patients all the time. I saw a patient last night, and she came in with tib post dysfunction. But when you saw how she walked, you just knew. When you saw her scan, she was externally rotating to offload, because her foot collapsed, loaded her big toe, and then she had to externally rotate really heavily. And when I examined her IT band, she was acutely painful. So she has two major problems, but the fact that her foot's loading very heavily through contact phase means that she's having to externally rotate because she can't bend her big toe. And that's why her IT band is really tight. So working on our IT band will certainly help her, but unless we do something to stop her foot loading really quickly, and unless we can get her moving through sagittal plane and not needing to laterally rotate, then that IT band is going to become tight again. So it's going to keep becoming tight again. So here is an example. We've got somebody who really quick through the rear foot. We've got a little bit of slow down. We've got rotation through the knee. And then when we look at a lot of the lateral problems, they all start once we get past here, because this is the anterior compartment of the shin. This will be your tibialis anterior. It'll be your shin bone itself, your tibial stress syndrome. Once we get to here, this is all hip. So I'm going to go back to this one. So this scan shows us that the foot's abducted. So first thing we would do is look at that and go, well, if foot's abducted, why? That's a flag. Is it IT band is externally rotating it? Is there an impingement in the hip which is stopping the foot? Can the foot actually rotate round and become straight? Because there's no point in us trying to effect a treatment to straighten that leg if the hip doesn't want to do that. Why, with rotation off second, third, and fourth metatarsals, is that going to cause an impingement? Is that going to cause a neurological impingement, a Morton's neuroma, or a plantar digital neuritis? Moving down, we have a foot which is externally rotating and rolling laterally. So if we use that example, you could have a foot which is definitely going to be laterally unstable, which is odd to see somebody, because a lot of these patients, when you see them standing, are going to be very flat-footed, very mobile, very flat-footed. And it's odd to think of them as somebody who's very laterally unstable. Everybody thinks, my goodness, they're just completely collapsed in. But when they walk, because being collapsed in and being mobile means that their big toe doesn't work, the way they gain momentum is rotation. They rotate, they open up their ATFL, their lateral complex, they open that up and they put a lot of stress through there. A lot of stress through the perineals, they put a lot of stress through their IT band, they switch off the glutes, tight piriformis, and they overwork their hip flexors. Okay. So what I want to do is I want to go back to the scans and just show you. So here's the difference between a scan, all forefoot, all the compensation that's happening at the forefoot here. There's a flag because, again, when you roll off the first MTP joint and you roll laterally, you're going to have issues 2, 3, 4, and 5. This is a classic position to have a Morton's neuroma. So when you see this happening, that should be a flag to think, test for that. Morton's neuroma, do a Mulder's click. You should look at that. You should test the lateral ligament complex. If somebody's very laterally rotated, I would always do some proprioception, some balance work, and check their ATFL and check their sinus tarsi. When you look at that as well on a foot, which is this foot especially, is a little bit externally rotated, you check to see whether or not their IT band is very tight. Now again, we talked about the system being an aid to diagnosis. This looks, for all intents and purposes, like the big toe joint doesn't work. So we could argue that this is a hallux rigidus. And it could be. But the only way we know this is by you investigating. You can't tell you can only determine a functional hallux limitus if the patient isn't standing, by the way. There's a lot of people who will examine a foot, have a patient standing and try and bend the big toe while they're standing in a static position. You can't do that because to do that forces the metatarsal heads into the ground. So to test first MTP joint, put the patient into the chair, hold the foot in some semblance of subtalar neutral. Just put your thumb medially underneath the medial calcaneum. Stop the talus sliding and bend the big toe. And if it bends past 50, 60 degrees, you're going to be good. So in this case, there's good range of movement. What you have to look out for is the case of this. Now again, no big toe, very little big toe. But this is a different one because this patient came into me, no movement through first MTP joint at all. And this patient's been going, they have seen so many practitioners, they have been getting work done on their IT band, they've been having work done on their hip, they've had x-rays on their hip. This person just has no other way to walk except to externally rotate. And previous to coming into my clinic, they had been issued an orthotic with a first metatarsal cutout to try to encourage the big toe to bend. The only thing that will encourage this big toe to bend is a hammer and chisel, unfortunately. So when the big toe doesn't bend, then we have to put note of that in the examination findings, and we have to make sure that we manufacture the orthotic, effectively. The one thing I would say to everybody is that since I took over as chief clinical officer, one of my first functions was to put together a new clinical team, and the clinical team we have now in place are, clinicians, and we are moving towards a state where we will be changing the exam findings on the GaitScan system on TCS so that you'll be able to give us a little bit more medical information, a bit more information, things such as does the big toe bend or not bend? Because if it doesn't bend, we can't put in a first met cutout. If it does bend, we can put in a first met cutout and encourage this foot to roll onto the big toe. If it doesn't bend, we put in a reverse a Morton's extension or a forefoot varus post. So we really want to start looking at how we do labs discretion from a more medical standpoint, based a little bit more on medical information and the scan combined. And you'll be able to use that. So you just by hitting labs discretion, it's going to go to a clinical team that's going to be using the medical information. Okay. So the role of the orthotic, I just want to bring this up just at the end. We've only got a few minutes. So role of an orthotic is very simple. It's not complicated. We want to control rear foot velocity, support the midfoot, and promote sagittal plane movement where possible. I should have added to the end. An orthotic can't put a foot into a specific position. We can't say, okay, we want this foot to, to be at 4 degrees varus. What we want to do is control how fast the foot hits the ground from an inverted to an everted position and control those forces. We want to support the midfoot, and by doing that, we hold the base of the first metatarsal up in the air and allow the head of the first metatarsal to drop. And we want to allow the big toe to bend where possible. So if this has a good range of movement, and you can tell us that, then we can encourage the foot to function in as close to a normal position as possible. If we don't know whether this bends, or if you're putting in a prescription, if you want to be able to encourage the foot to function as closely to a normal position as possible and to function in the sagittal plane, because when the foot functions through sagittal plane, the lower limb functions normally in a linear fashion. It's very simple. The treatment process, how to create a rehabilitation package that complements the function of the orthotic. And I think that is something I want you to take away today. Get the GaitScan out of the box. Get it used every day. Don't use it for a tool for saying everybody walks into my practice needs an orthotic, but everybody that walks into your practice, you're sitting with a really high-tech piece of kit which can give a really good aid to diagnosis and can help direct a patient to get more rehabilitation or more directed rehabilitation. And we want that rehabilitation is to complement the function of an orthotic if they do then go down the route of an orthotic. Because most of these people will ask, if you send them this scan, what you do is you go to report, you click print PDF, and you send this scan to every patient you scan, you send them the report, it goes onto their phone, they go out for lunch, they go out at the weekend, they're playing golf and they're showing it to their buddies. And they love doing it because everybody loves to compare notes, how bad their foot is. And that's a really good marketing tool for you. You can actually, it's a marketing tool that costs nothing, and people will then start asking you, do you do the scan? The second thing for the treatment process is how to manufacture an orthotic that controls aberrant foot function and allows the rehabilitation package to have its best effect. There is no point in having a rehabilitation package to stretch out the IT band and to work on your calf flexibility and then allow the foot just to collapse and then have to twist 1,000 times, 7,000 times, 10,000 times a day. I'm nearly done, but I'm going to throw these in at the end. This is how I practice. So this is just when I see patients, I have it very simplified. When I see a man, it's either a super flex or a run flex. When I see a woman, it's a dress flex or a court flex. The only reason I do this is because it keeps things very simple. At the end of the day, the plastic shell that we use, it's what controls the foot function, it and the posting we add to it. And then anything else we add, the adds and mods, will help just to control or to add a little bit of padding or elevation to certain areas to try to offload certain areas. So using this is something that you can look at in your practice. This is something I've done for 20 years. And at the start, when I bought this system way back in a long time ago, when I started, I was using all the different insoles and I was trying to use everything. Now I just use these. When I'm making an insole for a rheumatoid or arthritic patient or a diabetic patient, I go cushion flex, and I go cushion flex with a nice vinyl, with a nice double top layer, so linear made under a blue star suede. But this will be on the back of the presentation, and if you want any further information, please let Mike know, and he can get it to you. Okay, that is me for today. If anybody has any queries or any questions, be glad to hear them, and hope it stimulates a little bit of thought over the weekend of maybe how we use the GaitScan, and we think about lifting it out and dusting it off and using it a little bit more. Thanks very much for listening.
Fantastic, Paul. I appreciate it. And it does not look like we have any questions that have come up as of yet. But if you do have any questions later on, feel free to reach out to us. We will definitely love to answer those for you. Again, a copy of today's presentation will be available by Monday. And if you do not have a GaitScan and are interested, please reach out to us and we can help you facilitate that arrangement as well. It does conclude our webinar today. We hope you enjoyed the content. Thank you again for joining us. We do have some additional webinars coming up through about the 2nd of December, so please visit us at ohiuniversity.com for more information. Thanks, everyone. Thank you, Dr. Barrett, and have a great weekend.